Hello class, this is Kelly Neal, and today we're going to talk about infection control for the CNA. We're going to learn how to do some techniques to help keep our patients safe and how to keep ourselves safer so we don't get an infectious disease. We're also going to look at some isolation precautions. When we're talking about disease processes, generally we start thinking about microorganisms. Now, not all microorganisms are bad. For instance, we have bacteria that actually lives in our gut that helps us with digestion. So when we're talking about pathogens or germs, we're usually talking about microbes that have become harmful to the body. So there's bacteria, there's fungi, there's protozoa, rickettsia, and viruses. Now, viruses usually your body has to fight off for you. Your body's immune system has to kick in and it has to be able to fight that virus off. Where with bacteria, a lot of times we're going to be looking at antibiotics to help the person get rid of that bacteria. Microbes generally need a reservoir or a host to live in and to grow properly. And so when we're talking about a reservoir, it can be human or it can be animal. A lot of the viruses that we see nowadays have come from birds or from bats. We've gotten disease processes from pigs. So but a microbe, to keep growing, to keep surviving, it has to live in something or somebody. So that can be human or animal. And generally, most microbes need water and oxygen and some type of nourishment. They generally like warm, dark areas. Now, there are exceptions to that. There are some microbes that actually are okay in light. And there are some that can live without oxygen. But in general, most of your microbes are going to like warm, dark areas. So antibiotics are drugs that can kill certain types of microbes. And so generally our bacterial infections usually do need a type of antibiotic. Our fungi need an antifungal medication. So there's a bunch of different medications that we can use to kill certain microbes. But what we're seeing nowadays are what we call MDROs, multi-drug resistant organisms. And those are bacteria that don't respond anymore to antibiotics. And so an example of that is MRSA, which is methicillin-resistant Staphylococcus aureus. Staph aureus is everywhere. It's very prevalent in the community. And it used to be a drug that if it did start a bad infection in you, typical antibiotics would take care of it right away. But now what we're finding is our antibiotics aren't working anymore for a lot of these organisms. So Staph aureus, VRE, there's certain strains of tuberculosis that have become drug resistant. And that's really scary because if our antibiotics don't kill them and the person's infection gets really bad, it could be something that, it can kill them. That infection can go ahead and kill them because we don't have the antibiotics to take care of it. It used to be with MRSA, for instance, if you had a Staph aureus infection, you could take penicillin type derivative medication and it would usually take care of it right away. But now we're having to give people 2 and 3 antibiotics at one time to kill that organism, or we're having to give them something like vancomycin, which is a very hard duty antibiotic, which can be really hard on the kidneys and the body. And that's what we're having to use to kill these organisms. And one of the reasons this is happening is because antibiotics in the past have not been prescribed properly. It used to be if you had a virus and you were sick and you weren't getting better, we just give you an antibiotic, even though we know antibiotics don't really work on viruses. It was just easier to give an antibiotic. Well, maybe it might be something, so we'll just give you an antibiotic. And overprescription, overuse of antibiotics is one of the main reasons why we're starting to see a lot of organisms that have become drug resistant. The other reason is a lot of people don't take their medications correctly. So, for instance, if you get put on an antibiotic regime and let's say it's 10 days long that you're supposed to take it, generally after about 3 days you start feeling better, and after 5 days you actually are feeling pretty decent. So it's like, hey, I don't need to finish taking that. I'll save that in case I get sick the next time. But if you don't kill off all the organism, it can mutate, it can change, and then we start getting these drug-resistant organisms. So when we're talking about someone getting an infection, we're talking about a disease state that's resulting from microbes. So infections, harmful microbes. So infections can be local or systemic. And local, what we mean is the infection is contained to the area where it started from. So let's say you have a cut or let's say you got cut really bad on your arm, and now it's getting infected. So generally it will get red, it might be tender to touch, might feel a little hot, you might start noting pussy drainage coming from it. And so that means it's localized. It's all contained in that area where the cut or where the initial infection started. A systemic infection is when that infection is going to get into the bloodstream and it's going to get carried to the rest of the body. So you'll see fevers, increased heart rates, you might notice rashes, muscle aches, joint pain, headaches, chills. Those are some of the signs that that infection has actually become systemic. It's gone in and throughout the body. So the chain of infection, when we're looking at what is a chain of infection, it always starts with the pathogen or the germ or that harmful microbe. So there has to be a source. I mean, you can't have an infection without a source, without that initial pathogen that started it. Then that source has to live in a reservoir, which we said could be human or animal. Now, how is this pathogen that lives in this human, for instance, going to get over to another person to make them sick? Well, it has to have a way out of the body. So let's say you have an upper respiratory infection and you're coughing and sneezing. That would be a portal of exit, your mouth. The method of transmission, so even though it's coming out of my mouth, let's say I'm sneezing or coughing and I'm spewing droplets all over or out to the next person, that would be a method of transmission of how it's going to get carried over to another person. Now that person would have to have a portal of entry where it can actually enter into the body. So maybe they inhale the droplets or they breathe in those droplets. Now, that doesn't necessarily mean they're going to get the infection. They have to be susceptible to it. So not everybody that gets exposed to a cold is going to catch that cold, but certain people are more at risk for it, and the more exposed and the longer you stay exposed to an organism or a pathogen, the greater your risk is going to be. So generally, people who are susceptible to infections are very young or our elderly population. So the very young and the very old. So the very young, because their immune systems aren't well strengthened yet, and our elderly population, because they get weaker and their immune systems actually start to weaken. The really ill patient, the patient that is really been fighting off infections, they've been really sick, or people that just have weak immune systems, like burn patients, really bad burns, cancer patients that are going through, like chemotherapy treatments, it really weakens the immune system, transplant patients that have just had like a heart transplant or kidney transplant, their bodies tend to be weak, or HIV patients. So those people are going to be more at risk for an infection. And then people that are exposed to pathogens for extended periods of time, and healthcare providers, a lot of times we're going to fall into that category because we're exposed to a lot of different infectious disease processes. And a lot of times you'll take care of someone before you even know they have an infectious disease. There were many times that I would take care of a person in an emergency room because they came in because they were really sick and they were coughing. And then we find out, a day later that they've got tuberculosis. Well, I've already been exposed to it without the proper safety precautions on it. So healthcare providers are exposed a lot to organisms as well. Now, the term healthcare-associated infection, HAI, so healthcare-associated or healthcare-acquired, you can look at it either way. We used to call these nosocomial infections. And what a healthcare-acquired infection is, it's when a person comes into the hospital or they come into the facility and they don't have a disease process. Maybe they came in for a routine surgical procedure, or they came in for some kind of treatment, and while they were there, they ended up getting a wound, or they ended up their incisional site became infected. That would be a healthcare associated infection. Now, one of the most common healthcare acquired or healthcare associated infections is urinary tract infections. And one of the reasons that happens is the number one reason a urinary tract infection happens is because of tubes. So when a person has a urinary tube put in, that is a direct route for bacteria to crawl up that tube and up into the bladder. So urinary tubes increase the chance of a healthcare-acquired infection dramatically. Another cause of urinary tract infections could be improper cleaning. So cleaning someone incorrectly, instead of cleaning when you're doing pericare from going top to bottom, people are going from the bottom up and they're taking bacteria that's normally found in the stool or around the rectal area and bringing it up to the urinary tract, to the urethra, where it can just crawl up into the bladder. And this is one of the reasons why, when we talked about urinary incontinence, this is one of the reasons why we do not generally give urinary tubes to treat urinary incontinence. So if you're looking at the potential risk of being incontinent, when a person's incontinent, there's really a big risk of skin breakdown. But if you do good peri-care, good hygiene on a regular basis, you use protective barriers like A&D ointment or Balmex, those things will prevent skin breakdown. Urinary tract infection, you put that in and your risk of an HAI is going to go up tremendously. Much higher risk of getting a healthcare acquired infection from a urinary tube than there is from having skin breakdown from being incontinent. So, which is why we don't generally just treat it incontinence routinely. Now, if the person has a skin breakdown, for instance, on their bottom and we're trying to get it to heal, they may put a urinary tube in for that. Or if you have a patient that's dying, and we're not really worried about infectious issues at that point because they're already in the dying process and they're more comfortable with the urinary tube, we can do that. Another common healthcare acquired infection is pneumonia. Now, with pneumonias, you'll see this a lot in a hospital from breathing tubes. So again, tubes are great sources of infection, unfortunately. I mean, they're necessary sometimes and they're life-saving sometimes, but they're also sources of infection. So we see pneumonias a lot in patients that are on breathing tubes, but we also see pneumonia in the nursing home because a lot of our residents are on dysphagia precautions. Dysphagia, DYS in front of a word, means difficult, and the phasia is swallowing, so they have difficulty swallowing, and they're on specialty diets. They have to be fed really slowly. It's really easy for them to aspirate, where they breathe in food, fluid down into their lungs. So, and that can cause pneumonias. So we see pneumonias a lot in nursing homes as well. Diarrhea is another common healthcare acquired infection. So some of the organisms that can do that, there's norovirus, but there's also a really common one called C. difficile or Clostridium difficile. And Clostridium difficile usually happens because a lot of patients that we take care of are on high-dose antibiotics for these really bad infections. But the problem with antibiotics is it doesn't just kill the good bacteria. I mean, it doesn't kill just the bad bacteria, it kills the good bacteria as well. And so then that makes their gut more susceptible to getting an unusual organism in it, which can attack the gut and cause diarrhea. So C. difficile we tend to see when people have been on high doses of antibiotics. And then what happens, though, is when a person gets C. difficile, it can spread very easily to other people from poor hand washing or poor isolation techniques. So C. difficile, for instance, is a bacteria causing spore, and you can't get rid of it with just regular hand sanitizing. Normally, when we talk about hand sanitizing, we're going to say that hand sanitizing will usually kill 99% of your organisms out there, but it doesn't C. difficile, so you have to wash with soap and water. And C. difficile will live on inanimate objects, so anything that person touched, it can also live on it. So if we are in a patient's room taking care of them and we don't do good isolation techniques, good hand washing, and then we move over to another patient, it's really easy to give C. difficile to another patient. C. difficile has a very unique smell to it. It's something that once you've smelled it, you're probably never going to forget it. And then other infections that we see, infections of the skin and the mucous membranes, and so those are really common HAIs. So the term medical asepsis is the same as clean technique. So when we're referring to medical asepsis, we're talking about clean techniques, things that we can do to reduce the amount of microbes that we're exposed to and prevent them from spreading. We use medical asepsis to prevent contamination. This is not the same as surgical asepsis. Surgical asepsis is when you're dealing with sterile fields where everything has been sterilized. There's no disease-producing bacteria or spores anywhere around that area. As a CNA, we are not going to deal with sterile techniques. We are going to deal with medical asepsis. And one of the most important things that we can do to help prevent infection and to do our clean techniques is good hand washing. So it's one of the most important things we can do to prevent infection. We have to hand hygiene before and after we give care, and even in between care if we've got soiling on our gloves, or we're doing a procedure and we've contaminated our gloves, we may need to change them out, hand sanitize, put new gloves on to finish giving that care to that person. When you wash your hands, you need to scrub with friction for at least 20 seconds. So we're going to make sure we scrub the inside of our hands, the back of our hands, in between our fingers, our nail beds, up on our wrists. And I'm going to show you a video on how to do proper hand washing. This is a skill of state competency, hand washing is, and everybody who does state competency will do hand washing, and you have to do it for a minimum of 20 seconds. They don't care if you wash your hands for 5 minutes, but if you do it for 19 seconds, you just failed state competency. So keep in mind, when you think your 20 seconds is up, just keep doing it a little bit longer. Never let your hands touch the inside of the sink, and when we do turn off the faucets, we want to make sure we're using clean, dry paper towels. So we're going to wash our hands, rinse them really well, dry our hands off, and then get another clean, dry towel to actually turn the faucets off. Now, alcohol-based antiseptics are alcohol-based hand sanitizers. Like I said, it kills 99% of those germs. Doesn't work on C. difficile, doesn't work on anthrax. I'm trying to think. I think there's one other one it doesn't work on. But for most things, for most care, hand sanitizing is fine. And so generally you're going to hear the term when we go into a room, they're going to say gel in, gel out. You're going to hand sanitize as you walk in a room. You always hand sanitize as you walk out of a room. But remember, if your hands are visibly soiled, you need to wash them with soap and water. So it should be soap and water for C. difficile. It should be soap and water if your hands are visibly soiled. Soap and water if you're getting ready to go eat. Soap and water if you just went to the bathroom. So common aseptic practices: washing our hands, making sure we're providing clean linens, cleaning equipment between patients, making sure blood pressure cuffs, gait belts, that all of those things are wiped down before we take them to another patient. We need to make sure we're bathing our patients regularly, washing their hair, doing good oral care, and making sure they have their own personal care items. One of the things you're going to see when we get into the nursing home is their basin is going to be labeled with their name on it. Their hairbrush is going to be labeled with their name on it. Everybody has their own supplies, and their supplies should be labeled so we don't accidentally mix them up. And when we are doing care, when we're getting ready to do hygiene, we always line our surface area with a nice clean towel. So we set our things on the clean towel so they're not sitting right on the counter or right on the bedside table where dirty things might have touched at an earlier time. Gloves, as far as wearing gloves when we give care, we do not have to wear gloves every time we go into a patient room for every single thing that we do for them unless they're an isolation patient. So it is okay to go into a room just to talk to a person without gloves on, or to help get their clean clothes out of the closet, or to hand them things or get them water or feed them. Unless they're an isolation patient, we don't need gloves for that. You do need gloves if you're dealing with anything that could potentially touch their bodily fluids, and anything like basically any skill that you would do water with, like bathing, peri-care, oral care, denture care, foot care, nail care. Those you would make sure you would wear gloves for those. When we take gloves off, you pinch the first one at the palm of the hand or right at the wrist area. You pull it inside out and all the way over into your other hand. And then you slip your fingers under the other glove, and it's going to come underneath the glove and pull the second glove over the first one, and you throw them away. And I will show you a video on this as well. And even though that you gloved them, you want to make sure that you're washing your hands afterwards with soap and water or hand sanitizing. I thought this was a really cute little cartoon. It says, "Fascinating, isn't it, Gary?" They say those hairy little organisms actually live in our eyelashes, and so he's in there scrubbing his eyelashes. Yes, there's organisms everywhere. Not all organisms are bad. I mean, there are harmful organisms, which we consider pathogens or germs, but there are organisms everywhere, and we don't have to be afraid to touch people. We don't have to be afraid to touch things. We just have to remember good hygiene and good hand washing. As far as controlling transmission of microbes, we don't shake items out. We avoid splatters and splashes. don't sit on a patient's bed. And I see CNAs do this all the time. They're wanting to have a conversation and be friendly with the person, which is wonderful. And we always tell you it's best to talk to someone when you're at eye level. So pull up a chair and have a conversation. Otherwise, you're going to need to squat down and have that conversation. Because when you sit on their bed, if there's any organism, I mean, remember, if they have any organism and they've been touching their mouth and their hands, and now they're touching around their bedspread and their covers, pulling things up, and now you're sitting on that bed, and now you get up and you go into another patient's room and you sit on their bed, you're taking organisms from one room and taking them into another. Think of your uniform as being dirty. We don't put things on the floor. We don't put dirty linens on the floor. We don't throw things on the floor. You always want to make sure, I mean, you can put dirty linens in a bag and put the bag on the floor, but you don't throw things directly on the floor. Clean tubs and showers after use, clean bedpans and urinals after use, and if there's any pests or ants or anything like that, we want to make sure that we let maintenance know so they can come in and get that taken care of. You know, we tend to think of, oh, you would never have a pest problem in a hospital. I remember my very first job I did, a family member brought my patient in a big boom box. This was a long time ago, before you had all the music on your phones, but anyway, the family brought in this huge boom box for the patient to listen to music while he was there. And what had happened, we found out as we found cockroaches going up the wall and over the ceiling, that there had been a big nest of cockroaches inside the boom box. So if you find pests or ants or any type of problem like that, you want to make sure that you report that so it can get taken care of right away. As far as bloodborne pathogen standards, so pathogens can be transmitted in human blood like HIV or hepatitis. So healthcare facilities are required by law to offer training to their employees on how to prevent that from happening. So they have to implement safety measures. They are required to provide proper PPE for you, and preventative measures like hepatitis vaccinations should be done. And if you have any exposure to something, you want to make sure that you're reporting it in any way. Now, bloodborne pathogens also are very similar to just a standard precaution now. So standard precautions basically say that you're going to treat, when you're taking care of a patient, you are going to treat any potential bodily fluids, any contact bodily fluids. You're going to wear gloves. First, you're going to wash your hands before and after giving care. You're going to put gloves on if you have any potential contact with bodily fluids or you're touching things that bodily fluids could have been on. And you're going to wear a gown if you think things could splash up on you. And if you think things can get up in your face, you would need a mask and or goggles. Surgical asepsis, we said, is where everything is sterile, and as a CNA, we are not going to do sterile procedures or sterile techniques. So surgical asepsis, all items in contact with a patient must be sterile. Sterile fields cannot be touched by clean or dirty linens, and sterile fields always have to be, everything has to be up above the waist where you can see it. Now, if you're going in to help a nurse with a sterile procedure and this nurse has put a sterile field out and you think you've accidentally contaminated it or touched something, please be honest about it and just let them know so they can just set up a new sterile field so we don't risk infection for that person. So we're going to look at isolation precautions, and it says here on my little germ here who's eating, he says when everybody's living the dream and you just sit here isolating yourself. Most people don't think of isolation as a dream. It's something that we're very social people. We're meant to be social people, and generally when people are isolated and alone, they tend to feel unclean, they tend to feel depressed, and so it's something to keep in mind. Isolation is needed sometimes, but we need to still make sure we're making that connection with our residents and our patients. So standard precautions we've talked about. We do hand hygiene for everybody before we give care. PPE, or personal protective equipment, if we think soiling or splashing may occur. Respiratory hygiene, so if you have to sneeze, you do it in the corner of your elbow or you use a Kleenex, and you teach your patients to do that. And don't just leave if they leave dirty Kleenex laying all over the place, put some gloves on and pick it all up. That's a chance for potential infection. Use clean equipment. Make sure we're cleaning equipment in between each use for our residents. Care of the environment, making sure they're in a nice, safe, clean environment. And worker safety. If you see anything sharp, if you're shaving someone, razors always go in a sharps container, or if you find like the nurse left a needle or something sharp in the room, make sure it goes in a sharps container. Now, the only thing you should put in sharps containers are sharps. Don't put garbage in there, because the facilities have to pay extra money to have sharps containers disposed of correctly. So if you're just dumping regular trash in there, they're having to waste a lot of money. And if you're exposed to something, you know, somebody bleeds on you, or, you know, you get something splashed up in your face or your eye or anything like that, please let your clinical instructor know. And then once you get your regular job, let the charge nurse know, because we have a process that we'll go through to help you with that, to make sure we're keeping you safe. So transmission-based precautions, there's contact precautions, there's droplet precautions, and there's airborne precautions. So one thing I will mention is when you get report in the morning, so when we give you your patient assignment and we don't tell you that the patient is on isolation, and you get to the patient room and you see a sign on the door and it says stop, please report to the nurse's station before entering, and it'll say hand washing on entering and leaving, gloves and gown if there's contact with patient or potentially contaminated surfaces. Please come back and talk to your clinical instructor or talk to the nurse and just find out why they're on isolation, so you know exactly what's going on and what you need to do to keep yourself safe. So personal protective equipment. How we put our gown on, how we take it off, our equipment is really important. So when we put our personal protective equipment on, gown goes on first, then our mask. Now, if we're wearing a face shield, it would go gown, mask, face shield, and then our gloves. And we keep our hands away from our face. So once you get all gowned and gloved up, of course, something's going to itch, or your nose is going to bother you, or you're going to need to sneeze. But it's really important that you try to keep your hands away from your face. We work from clean to dirty. We limit what we touch. And anytime your PPE is soiled, even if you're doing a procedure for the patient, you're halfway through it, but you're completely soiled and you feel like you're just contaminating everything, you may actually have to change out and put on new PPE to finish it up. And always we do hand hygiene before we even started the whole process of putting our equipment on, and after we take it off, we hand hygiene. Now, when we're taking off our equipment, the gloves come off first. So imagine your gloves saturated with bodily fluids. You don't want to be reaching behind you to untie your gown, or putting up near your face to take off your mask. So gloves come off first because they're the most contaminated. Then the gown comes off, and you want to take it off slowly and roll it in a ball. And then the mask comes off, and it goes into the garbage after use. And then, of course, we would hand hygiene. Now, the different types of isolation I mentioned, contact isolation, droplet isolation, and airborne. We'll start with contact. Contact is probably the most common that we're going to see in the nursing home. Contact isolation would be for someone who has an infected wound, has diarrhea. We would do contact isolation. And generally with contact isolation, single rooms are best if you can. Now, most hospitals have single rooms nowadays. Or most newer ones have single rooms. But a lot of the nursing homes are really old, and they weren't made with private rooms, and they're not equipped to handle a lot of private care patients. So generally there's 2 or 3 patients in a room. So if you can't put a patient on isolation in a private room, we recommend cohorting. And what cohorting is if Mrs. H has C. diff and Mrs. W has C. diff, I can put them in the same room, okay? Because I'm not worried about giving the C. diff from that patient to that patient, because they both already have it. So cohorting is putting 2 patients with the same disease process in the same room if you don't have single patient rooms. Gloves, of course, will be worn whenever we're touching the patient or when we're touching their belongings. And gowns will be worn if you think clothing will come in contact with the patient or their belongings. And the patients are going to need really frequent cleaning and disinfecting. Now, one thing I want to say about contact isolation, I see a lot of nurses, they'll put their gown and gloves on before they'll even walk into the room. But generally what I usually tell my students is, let's say the patient puts their light on. Let's say Mrs. W puts her light on. If I put my gown and my gloves on and I knock on the door and I go into the room and she says, oh, hey, could you just tell the nurse I'm ready for my pain medicine? I just wasted a gown and a glove. I didn't even touch her. I didn't even come near her things. She just wanted me to pass something on. So I generally like to just open the door, say, hi, it's me, Kelly. What can I get for you? And if she says, oh, could you just tell so-and-so something, then I know I don't need to bother getting my gown and gloves on. If she says, oh, hey, could you help me do this or help me get to the bathroom? Then I say, sure, I'll be right in there. Let me just get my gown and gloves on. Okay. But if I'm not touching her, I'm not touching her things, I can pop my head in the door and say hi and see what she needs before I get all that gear on. Droplet and airborne are a little bit different. Now, droplet, think of when you sneeze, how you see that spew of water come out of your mouth and fly across the room. Droplets can go about 5 feet generally. So with droplets, if you're going to come within 5 feet of that patient, you need to have your gown and your gloves on and your mask, gown, gloves, and mask. Okay. So if the rooms are small, you may need to put your gear on before you even walk in that room. But ideally, if I can, depending on how the room is, again, single rooms or cohorting is best. Gown, mask, and gloves should be worn if we're going to be within 5 feet of the person. So if I can, I like to just at least poke my head in the door and say, hi, it's me, Kelly. I just wanted to say hi, so they can see your face, so they can actually make a better connection with you. And then I'll stop and I'll get all my gear on. Now, airborne is different though. Airborne, you have to have all of your gear on before you go into that room. You cannot poke your head in without your mask and all your gear on. So airborne precautions, they have to have a private room and they need a HEPA filter in place. A HEPA filter is a filter that's going to filter all the air in the room. It's going to filter, it usually filters the air in the room every hour. You're going to need a gown, gloves, and mask, and usually you'll wear a fit-tested N95 respirator mask. If it's TB or if it's COVID-19, you're going to want to make sure that you've got that fit-tested N95 respirator mask on before you go into that room. Door has to be closed at all times. Now, when you're in airborne precautions, so I've got my gown, gloves, my N95 respirator mask, and you may even be wearing a face shield or goggles. I'm going to go in that room and do my care. As I'm coming out of the room, I can take my gloves off and I can take my gown off and leave it at the garbage right there. And then I'm going to step out of that room, hand sanitize, and now I'm going to take my face shield and my mask off. You do not want to take your mask off while you're in that room because it's airborne. And the minute you take your mask off, if you're still in that room, you're going to be breathing it in. So the mask part's going to actually come off after you get out the door. I loved this cartoon. I think it's so appropriate. It says you've just come out of an isolation room, you've peeled everything off, and they ring their call bell again. Never fails. So just keep in mind when you're leaving an isolation room, before you walk out that door, you want to ask them, well, one, make sure the bed's in low position, make sure their call light's in reach, make sure they can reach everything that they need, do a safety check of that room, and then just ask them before I leave, is there anything else I can get you? Okay, is there anything else I can do for you before I take my gear off? Okay, and if not, then just say, you know what, I'll be back in a little bit, to check on you. And that way, a lot of times you may prevent that because it's pretty frustrating when you get all your gear off and you have to put it all back on to go right back in there. Now, as far as transporting a patient who's on isolation, so when a patient's on isolation, when you go in the room, you're in isolation gear. When you bring the patient out of the room, because let's say you have to take them down for some kind of test, they go in isolation. So they're put in the isolation gear and they'll have a clean sheet over them as well. As far as meeting basic needs with isolation, PPE can be really scary to young children, can be really scary to our confused elderly patient, especially our patients that have dementia. So let that person see your face if at all possible before you put on that mask if possible. Now, granted, if it's airborne, that's not going to be an option for you, but for contact, it probably will be. Try to talk to them calmly and quietly. Try not to rush the person. And don't be afraid to make human contact with a person. Just because they're on isolation, don't be afraid to go in that room. Just take the proper precautions. These people are scared and they feel alone and they feel isolated. They feel dirty. They feel like nobody wants to be in there with them. And so we still need to give them that sense of connection. It's going to be really important. So always treat that person with dignity and with respect. I thought this was cute. It's just trying to leave a patient's room, but they keep on talking. Sometimes you just have so much to do and you're trying to get out of that patient's room. I just thought this was very appropriate somehow. Now, as far as bagging items that are contaminated with bodily fluids, if you have something that's really saturated with bodily fluids, we will always double bag. A lot of times, depending on where you work, airborne precautions, they may still double bag. We don't always double bag everything coming out of a contact isolation room, though. So, for instance, trash, a lot of times you would bag up the trash in the room, and then there would be somebody right outside the room with a biohazard bag, and you would dump your trash into that biohazard bag, and then they would end up taking it out. So everything's double bagged. But typically, most linen and most garbage now from healthcare institutions are treated as if they are disposed of as if they are contaminated. So you're really going to need to follow your facility's policy on the double bagging. But we will show you how to double bag in the clinical setting. Okay. So basically, with isolation precautions, keep in mind hand hygiene is extremely important. It will help break that chain of infection. It's one of the single most important things you can do to keep your residents from getting sick, to keep you from getting things as well. So good hand washing for a minimum of 20 seconds, getting all surfaces of our hands and up on our wrists. The proper PPE. So do you need to be wearing gown and gloves and mask and face shield? Depending on the type of isolation, you might, depending on what the situation is. Decontamination processes, keeping the environment clean, making sure that things are getting wiped down regularly, cleaning supplies in between patients, very important. Waste management. Do we need to double bag? Do we need to double bag everything that comes out of that room, depending on what your facility's policy is and what type of isolation or why the person's on isolation? That may be something we're doing. Linen and laundry, okay, dirty linens and stuff, again, do they need to be double bagged? Where do we need to put linens and laundry that are from an isolation patient so we can make sure that the next person dealing with that linen is taking care of the proper precautions? Patient transport. So again, if we bring a patient out of an isolation room, they go in isolation gear. So when you go in an isolation room, you're in your gear. When you are taking a patient out of their room, they go in the gear, and then you actually come out of it, okay, when you come out. And then patient placement. Where's the best place for that patient to be? Preferably a single private room. That's always going to be your best bet with isolation patients. But if you don't have that, can we cohort our patients? Can we put 2 patients with the same disease process in the same room? So that is going to end our talk on isolation, but I am going to show you some videos on how to do proper hand washing, how to do our gowning and gloving.